Well, good afternoon. It's my pleasure to take the next talk and actually the next two talks, which are related. And I opted to do it this way because I think it's worth a review of basic principles of mechanical ventilation, which is so important, especially now in the COVID era, as we've seen. And that'll help lay the groundwork for the second talk, which will be on respiratory failure and management strategies through. So let's talk first about the very basics of why we mechanically ventilate anybody in the first place. And I think this topic is very difficult for people who don't manage ventilators routinely. So I really am coming back to the basics on this. But we manage patients on mechanical ventilation for really only a few reasons. One is that they're hypoxic. They need simply a greater delivery of supplemental oxygen that they can't get otherwise. Hypercapnia, of course, that is that they can't ventilate. They can't blow down their PCO2 to manage their pH. For some patients, excessive work of breathing will eventually lead to either respiratory muscle failure, and that's a potential catastrophe. And then finally, we do intubate some people and mechanically ventilate them for their inability to manage their airway. So the goals, which is really what we're talking about, is to manage oxygenation, guarantee alveolar ventilation, so PCO2 is maintained. We want to avoid harm, which is one of the guiding principles of what we will talk about in the second talk here. We want to optimize comfort as compassionate caregivers, and because if we don't, then we have to medicate them, which is really not an optimal goal. And then also a guiding principle here is to extubate or to remove mechanical support as soon as is possible, also in the spirit of minimizing harm. We only have a few variables, what we're talking about, that we actually can control. And when we talk about pressure and volume, we're really talking about patients' compliance. The pressure-volume relationship really talks about compliance, both static and dynamic, and we'll come back to that in a moment. And then there's the pressure and flow relationship, which really is a surrogate or the variables that govern resistance. We'll come back to that as well. So it's pressure, volume, flow, and we also can control time. In a moment, we'll talk about what triggering and cycling mean. And so just to start with, again, basics of mechanical ventilation. Triggering is really just a term for when the mechanical ventilator initiates the inspiratory phase of the cycle. And that can be done in several ways. If we're using time, let's say we're giving a patient 10 breaths per minute, then every 6 seconds, the ventilator will know to begin triggering, auto-triggering the inspiratory cycle. Now, if a patient is being managed on a spontaneous mode of ventilation so that they are responsible for initiating the breath, then what the ventilator will sense is that pressure, that negative pressure inflection that they generate from their diaphragm, that will trigger the ventilator to trigger the support that's dialed in. And similarly, in patients who are spontaneously initiating breaths, flow itself, similar to pressure, may be what triggers the ventilator. Cycling is the opposite. It's what the ventilator uses to understand that it's now time to stop the inspiratory phase of ventilation and move to exhalation. And that can also be done with a time. Again, if a certain amount of time goes by and the ventilator will switch to the expiratory phase. Again, if it's flow, then as flow decreases to a certain preset level, it will cycle into exhalation. And volume, if a pre-designated volume is set, let's say you ask the ventilator to give the patient a 500 cc tidal volume, when that volume is delivered, the machine will then cycle to exhalation. Now, I want to disavow any notions that the actual mode of ventilation is that important. I know that people get very concerned about it. There are many, many modes of ventilation. Most of them are proprietary. They're almost all variants of the same thing. And I just want to make sure that you understand that there are really 3 modes of ventilation that are overwhelmingly used for the mechanical ventilation of the overwhelming number of patients. So those are the only three modes of ventilation I will talk about today. And really, if the board thinks any differently and asks about any other modes of ventilation, I would be quite disappointed. I think that would be a very poor choice. These are the modes of ventilation that ventilate probably greater than 98% of our patients. So that's assist control, pressure support, and pressure control ventilation. Perhaps pressure control slightly less common. So let's talk about what those modes of ventilation offer. Assist control is a volume-targeted ventilation. You preset the volume, the ventilator delivers that volume. It's a guaranteed volume. And even if the patient starts to breathe on their own, doesn't, initiates a breath, that's the volume that will be delivered. No matter how much effort they give, that's the targeted ventilation that they will receive. Pressure control ventilation targets a pressure. And when that happens, the amount of volume that's delivered is going to depend on the patient's lung compliance, or I should say the respiratory system compliance. So these are two different strategies for ventilating people, and we'll talk in the next talk about why we might choose one over the other. And then finally, we have pressure support ventilation, which is spontaneous ventilation. The patient takes a breath, it's supported by a certain amount of pressure, and then it cycles off. So we just mentioned the definitions of what triggering is. It's when the ventilator initiates a breath, or the patient does. In assist control ventilation, it's either the patient initiating a breath, in which case it will be supported to that preset volume, or the timer. So if 10 breaths are dialed into the machine, every 6 seconds the patient will get a breath. For pressure control ventilation, it's the patient or a timer as well that will trigger the inspiration. Pressure support is different. That's a spontaneous mode, and only the patient can initiate or trigger a breath in pressure support. Termination of the breath, or what we're calling cycling, is done with volume in assist control. When that preset volume is delivered, it cycles off. In pressure control, it's a timer, so that inspiratory time, when that runs out, then the patient will be cycled into exhalation. And that's important because that's the mode of ventilation where you may have heard we can inverse the I to E ratio, the inspiratory and expiratory ratio. Normally it's about 1 to 3, but sometimes we like to increase the time of inspiration. Pressure control ventilation is the mode we do that. And then in pressure support ventilation, cycling occurs by a flow. When flow comes down to a certain preset level, it will cycle into exhalation. Now, we have variables, other variables that we can control. And of course, all three of these modes allow us to control patients' FiO2 and PEEP, positive end expiratory pressure. Inspiratory flow rate is controlled in assist control, and that's sometimes very important for patient comfort because some patients, especially if they exhibit signs of air hunger, simply want the breath quicker, and we can somewhat control that as in assist control. And as we said before, the inspiratory time is the one that's controlled in pressure control, and that can sometimes be very important in the management of patients with ARDS. So very briefly, assist control ventilation, it's really the most commonly used mode worldwide. All breaths are assisted, whether the patient initiates it or otherwise. It gives precise control of tidal volume and minute ventilation. It gives us a guaranteed minute ventilation, which is really critical. For example, when somebody is first acutely ill and maybe first intubated and under the influence of sedatives or the medications used to intubate, or patients coming out of the operating room. So assist control is used so broadly, it is the most common mode of ventilation. The downsides are that when you use volume as your variable, you lose control of pressure. So if you dial in that the patient should get 500 cc's of volume, well, if the patient has very stiff lungs, that could require very high pressures, and that could be injurious, and we will talk about that later. But it's important to know that pressure and volume are so intimately related that you only control one and you relinquish control of the other by doing so. Assist control is not considered a weaning mode, although I suppose anybody could be weaned on almost any mode, but it's certainly not thought of that way. Pressure support ventilation, on the other hand, is what is considered more the weaning mode. It gives patients ultimate control of respiration, and it is the most commonly used mode of ventilation for weaning, although weaning itself has sort of fallen out of favor. And finding when patients are ready for extubation is usually done without what we traditionally think of as weaning. But certainly when patients are waking up and recovering, they're almost always placed on pressure support because it allows them to take control, which is usually more comfortable for them. The downside, of course, is that there's no guaranteed minute ventilation. So if for whatever reason their breathing rate declines, then they will simply have less minute ventilation, and there's no backup rate for this. So it's usually only used for people who are initiating breaths and on recovery. Pressure control ventilation is perhaps used less commonly, but certainly more so, I would say, in recent days because of the pandemic. It's a control of pressure during the inspiratory phase of the respiratory cycle, and it's used in cases of severe hypoxemia because, again, this is the mode of ventilation that allows us to manipulate the inspiratory and expiratory ratio, and sometimes that's important for people who are hypoxic. Having a longer period of inhalation and inspiratory time can be very beneficial and allow for greater gas exchange. It does provide a backup rate, but again, because this is a pressure-controlled mode, there's no guaranteed minute ventilation. So let's talk for a bit about the mechanics and why we should care. If this is just a case of a 25-year-old with a narcotic overdose who's intubated for airway protection. His initial ventilator settings are on assist control with a rate of 10. His tidal volume is 500. We have a PEEP of 5 and a flow of 60 liters per minute. His FiO2 is 100%. He has a peak inspiratory pressure of 20 and a plateau pressure of 15. And we're going to talk about that in a second and measure his compliance. So what is a peak and a plateau pressure? Well, on a mechanical ventilator, you are given patients inspiratory pressures, and it's generally measured in real time as a peak pressure. If flow is stopped and the pressure or within the airways is allowed to equilibrate, the pressure drops from the peak pressure as flow stops because there's no longer resistance. That lower pressure is called a plateau pressure. So it's really the difference between a dynamic compliance where flow is still going on and a static compliance where flow has stopped. We get a plateau pressure. So if we want to measure compliance, we want to do volume over pressure, the change in volume over the change in pressure. And to do that, we take the tidal volume, because that's the change in volume, and we measure it over the change in pressure, which in this case, for a static compliance measurement, would be that plateau pressure minus the PEEP, because that's going to be the change in the pressure from here, the plateau pressure, down to PEEP, where expiratory pressure then is held. And so in this case, we would get a 500 cc tidal volume. The difference between a plateau pressure of 15 and 5 is 10. So that would give us a plateau pressure of 50, and that's normal. Why is that important? Well, the difference between resistance problems and compliance problems can be very diagnostically important. A resistance problem would be when there's a large difference between the peak and the plateau pressures. And that's because if there's high resistance, let's say from something like bronchospasm, and then you stop airflow and that resistance is no longer calculated in that pressure measurement, then the plateau pressure is going to drop, but you still have had a high peak pressure. So there's quite a difference in the two. And that can be very diagnostically important because it can help distinguish between compliance problems. The compliance problem is when the lung itself gets stiff or it requires a greater pressure to inflate it for a variety of reasons, but it's not a resistance problem. And so something, for example, I'll give you examples on the next slide where an example of a compliance problem would be ARDS. That's one of the classic ones where the lung itself is getting very stiff. It takes greater pressure to inflate it, but it would also not change the plateau pressures. Normally, the difference between peak and plateau pressures are only about 5 to 10 centimeters of water. So in somebody who's getting increasingly stiff lungs, the peak and plateau pressures would rise pretty much proportionately. That would hold true for pneumonia, congestive heart failure, flash pulmonary edema, and similarly, a large pleural effusion or a pneumothorax, not a resistance problem, but it would be calculated as a compliance problem because it would increase the pressure required to inflate the lung. Resistance problems would include things like a kinked or bitten ET tube if somebody's biting down. Bronchospasm, of course, would be the more typical, what we might see, or somebody with asthma or COPD flare. Let's move on to complications of mechanical ventilation. One of the most important things that we do is try to avoid complications. And so there's ventilator-induced lung injuries. If we overventilate and overstretch, ventilator-associated pneumonias. Oxygen toxicity has had a lot of interesting data recently. And then, of course, there's decreased cardiac preload. If there's a high pressure in the chest, it decreases cardiac preload, and gastric stress ulceration. This is a very commonly used slide just to show that if we overventilate, the risks we have are that we can fracture the very fragile structures of the alveolar capillary membrane. On the left, you can see a fractured capillary with what looks like a red blood cell extruding, and an alveolus with exposed collagen fibers. And the consequence of that is a pneumothorax. That's what you would see at the bedside. If a alveolar structure is damaged, you would see escape of air. This is a tension pneumothorax because you can see that the mediastinum is shifted, and that's an emergency. The board seems to like to ask a lot of questions about intrinsic PEEP. So let's just say a quick word about that. This is, if you imagine a patient delivered a breath and then begins to exhale, if that exhalation is still ongoing when the next breath is delivered, then there's still air within the lungs, and yet the next breath is going to be piled on top of that. And that's really what's called air stacking or dynamic hyperinflation. That's also known as intrinsic PEEP. It's when you haven't had the chance to fully exhale before the next breath is delivered. That can have consequences because, as we just said, it does increase intrathoracic pressure. It can therefore decrease cardiac preload, and we can see hemodynamic consequence from that. This is usually only seen in people with obstructive lung disease who simply need more time to exhale. If they have bad obstructive lung disease, asthma would be another example, and sometimes simply allowing more time for exhalation is all that's needed. But it can cause great discomfort for patients, desynchronous breathing, and then, of course, barotrauma and hypotension, as we just said. So it is very important. The ways to deal with it is if you can decrease the respiratory rate, that's probably the best way to do it, but that's sometimes difficult. Decreasing the tidal volume similarly can allow for greater exhalation of that tidal volume before the next one is delivered. Increasing the inspiratory flow can sometimes be helpful because it shortens the inspiratory time, so it can slightly increase the expiratory time. And when all else fails, it is correct if the board asks, is it appropriate to increase the PEEP that's dialed on the ventilator, that's extrinsic PEEP. Intrinsic PEEP is what we have within ourselves. Extrinsic would relate to the mechanical ventilator. Increasing the extrinsic PEEP can actually be helpful. It takes that burden away from the patient. I would be remiss if I didn't at least say a word about the exit strategy, and that's so important. We don't really like to use the term weaning anymore, but liberation from mechanical ventilation, or at least the exit strategy is what we're referring to. It's really a two-part process, the first of which is to say, is this patient ready to be extubated? You know, what were the initial reasons they were intubated, and has that been addressed? Is the patient hemodynamically stable? Can they protect their airway? Are they not requiring too much oxygen anymore? And is their PEEP not very high, suggesting that if they really need a lot of PEEP and they wouldn't get it when you extubate them, they may not be ready. The standard of care now is to pair a spontaneous breathing trial with a spontaneous awakening trial. And what that means is that a spontaneous breathing trial is where we basically reduce the amount of ventilatory support to a minimum level Sometimes it's pressure support with just 5 centimeters of water support and 5 of PEEP. And then we also, for those patients who are on continuous sedation, we will pause their sedatives and allow them to wake up, hence spontaneous awakening. And when those two things are paired, it really has shown to improve outcomes, and that has become the standard of care. So in summary, real quickly, the indications for mechanical ventilation are really just ventilation, adequate minute ventilation and management of PCO2 and pH, adequate oxygenation, adequate airway protection. Our goals are to guarantee those adequate ventilation, oxygenation, and to manage patients' comfort, of course, and minimize harm. We don't want to contribute to patients' lung injury, but if we don't manage their ventilator well, we absolutely can do that. The variables that we have at hand are pressure, volume, flow, and time. And we talked about what triggering and cycling means. And in terms of mechanics, we talked briefly about dynamic and static compliance, which are really surrogates for that is that we get them from peak and plateau pressure measurements. We want to avoid the complications of mechanical support, including barotrauma and volutrauma, where we are allowing the lungs to alveoli to de-recruit and re-recruit and open and close. That's actually harmful as well. And of course, we want to get patients off ventilators quickly before they can get ventilator-associated pneumonias. Lung protective ventilation and strategies we'll talk about on the next talk. And then we talked about how we pair spontaneous awakening trials and spontaneous breathing trials as our exit strategy. So let me just ask this question. It's a 67-year-old man admitted to the ICU for multifocal pneumonia. He has a history of COPD, coronary artery disease, and hypertension. He's intubated and placed on assist control with a tidal volume of 500, which is approximately 6 mLs per kilogram. So that's lung protective ventilation. His respiratory rate 16, his PEEP 7.5, and his FiO 2.5. Suddenly, several hours later, his ventilator alarm goes off for high inspiratory pressures, and the peak pressure is reading 45, but the plateau pressure is only reading 20. So what's the most likely cause of this alarm? Is it tension pneumothorax? Is it that the endotracheal tube migrated into his main stem bronchus? His pneumonia's gotten worse? Has he had an MI, and this is congestive heart failure? Or has he had a mucus plug? Yeah, that's terrific. I would agree with the majority that that this is a patient who likely had a mucus plug. It's really the only of the 5 possibilities that really represents a resistance problem. So attention pneumothorax really is, and you can think of it as somewhat stiffening the inflation or stiffening the lung without creating any additional resistance, right? It's sort of like almost like fluid, but it's air that's compressing the outside of the lung. If the endotracheal tube had migrated into his main stem bronchus, there wouldn't be a resistance problem, but the ventilator would pop off a pressure alarm because you're essentially ventilating a one lung, and that would create much higher pressure. If the pneumonia were worse, or if he had congestive heart failure, that would affect his compliance, but not resistance. So I agree with the overwhelming majority of you. And the next question is about the same patient. So let's say that the patient in question 1 seems to be improving. How do you know if he's ready to extubate? Do we just extubate and hope for the best? Do we slowly decrease his ventilatory support and check blood gases at each step, and then extubate when he tolerates the minimal support? See, if his X-ray is improved, he should be ready to extubate. We do a spontaneous breathing trial and combine it with a pause in his sedation if he's on sedation. Or E, if his FiO2 is less than 60% and his PEEP less than 10, he should be ready to extubate. All right, that's fantastic. I would agree, and I'm glad everybody is thinking the same thing. So, extubating and hoping for the best, I think, obviously, is probably not a good plan. But choice B is really what we used to do, but we've learned the hard way a long time ago that delays patients who are ready to extubate sooner. Improving X-ray often is a sign that patients are ready, and similarly, in choice E, if their FiO2 is less than 60 and PEEP less than 10, they should be ready, or they may be ready, but you still don't know if they're ready from other regards, whether they still haven't been tested for with a spontaneous breathing trial, which really is what has become the standard of care. So that brings us to the end, and I guess I have about a minute or so left. Maybe I'll just ask myself one question from the chat. The utility of a rapid shallow breathing index, which is certainly has been promoted for many years and was what would be considered the standard of care several years ago. We've sort of gotten out of favor of using a rapid shallow breathing index in favor of just doing a spontaneous breathing trial, in part because there are patients who will probably never pass the rapid shallow breathing index to the standard that was given. So the studies that looked at it used a rapid shallow breathing index around 105, but we do know that there are patients either because they have chronic lung disease or either interstitial lung disease, for example, where they're simply going to be under normal circumstances breathing rapid and shallow, and just that may not be the best way to do it. And really what we want to know is what is the real world way of understanding whether they're ready, and that's simply to take them off as much support as possible. Some people even advocate for doing a spontaneous breathing trial with no support whatsoever, but most people, I would say, will still use a pressure support with 5 of PEEP and 5 of pressure support as their spontaneous breathing trial. So we've sort of moved away from the rapid shallow breathing index. I think for the sake of time, what I'm going to do is try to answer some of the other questions at the very end of the session later on.